All right, it is a great pleasure to present the speaker of today. I think it's the last speaker for the year for our conference, Dr. Carlos Torres-Cabela. He is an associate professor of dermatology and pathology at the University of Texas MD Anderson Cancer Center in Houston. He's also section chief of the dermatology section in the same institution. Carlos obtained his medical degree from the Universidad Nacional de Santa Agustín School of Medicine in Arequipa, Peru, and he did a clinical residency in anatomic and clinical pathology at the Universidad Peruana Cayetano Heredia in Lima. He then came to the States for postdoctoral training with a research fellowship in molecular pathology at the National Cancer Institute, working with Dr. Marino and with Marston Linian, studying von Hippel-Lindau and Berthold-Wade genes. He then trained in anatomic pathology at the same institution at the National Institute of Health, and he did a clinical residency, clinical fellowship in dermatopathology at the University of Texas MD Anderson Cancer Center, where he remained as faculty. Dr. CTorresCabela is a member of the executive committee of the International Society of Dermatopathology. He lectured in multiple US and international meetings on dermatopathology and authored more than 140 papers, particularly in the field of cutaneous, lymphoma, and melanocytic lesions. Today, Carlos' talk will be on cutaneous lymphoma and how we can integrate clinical information, histopathology, and molecular study in our practice. Carlos?
Well, thank you so much for, I don't know if you can hear me. So first of all, it's an honor for me to be here. I was thrilled to know that University of Minnesota and of course my friend Alessio invited me. And I know you guys are very strong in research and do really amazing things, but I guess probably as a refresher for you, I'm gonna talk a little bit more of traditional pathology. Of course, there is some molecular aspects and immuno and all this stuff, but as dermpath, you may know that we rely a lot on the clinical information from our colleagues, and I'm glad that a dermatologist is here with us. And we try to integrate that every day. And if a topic is, one of those that need more clinical pathologic correlation, is actually skin lymphomas, and that's why I actually love this area. So if you want to take, especially for the residents in the room, I think they are all in the back, but it's fine. I know that. I used to do the same. If you want to take something from this 45, 50 minutes lecture, is clinical pathological correlation. So when I talk about this and I ask my fellows at MD Anderson, I give them the clue and I say, whenever I ask a question, the answer is clinical pathological correlation. So if I ask you a question, guys, you know the answer. Of course, there is some molecular stuff and some immunohistochemical stuff that we want to know and I want you to be aware of. And let's go. So this is from Dr. Jaffe. So Alessio and I trained both at NIH, and Dr. Elaine Jaffe, as you know, is very well known. And she gave me, graciously, she gave me this slide like many years ago. I don't know, I'm going to say how many. And I use it all the time because it's very pertinent. So for the residents, again, and for all of you who are not really familiar with this topic, if you know that most of the cases you're going to see, most of the skin lymphomas you're going to encounter in your practice are T-cell lymphomas, then you have like 50% of your diagnosis because 75% of the lymphomas are going to be T-cell. And those are the ones we capture in dermpath. So the B-cells, sometimes they find their way through HemePad, although we fight a lot. I don't know how about here, but dermpath and HemePad, we try to find a way to be in good terms, and actually we collaborate a lot at MD Anderson. But most of the cases are going to be T cells. This is the 2016 or 18 revision of the WHO classification that I'm going to mention a few times because there are some new things that you may want to know, and that this is the specific percentages. Again, most of the cases are going to be T cell, 25% of the cases are going to be B cells. And this is the long list of entities that you have to know by heart, right? Like 35 different entities, and just primary cutaneous lymphomas that I'm sure you're gonna memorize, and I'm kidding. I'm gonna just gonna talk about some of them that I think they're the ones that are more interesting. Okay, so first basics, right? And this is maybe some very basic for some of you, but I think it's good to start with and be in, mood for mycosis fungoides. So mycosis fungoides is the most common one. So if you have the luck to encounter a cutaneous lymphoma, it's going to be mycosis fungoides most likely. And there are many variants. That is the typical clinical presentation, a patient who comes to you with a long history, usually months or even sometimes years, of something that looks like chronic eczema in non-sun exposed areas. I don't have to mention what is this non-sun exposed area. Then we have the lesions that come, present as patches, then become plaques and sometimes become tumors and then ulcerate. So that's the typical case of mycosis fungoides. If you have that, you have 50% of your diagnosis. So then you have to have very good communication with your clinician, with your dermatologist. Now is the era of communication, right? Pathologists are not in the basement anymore. You have nice windows and phones and texts. So you have to communicate with your clinician. So what is the most difficult issue for you is to make the diagnosis of early mycosis fungoides, because that looks like dermatitis, like eczema, like anything. And there's a long list of diseases that look like MF, and MF looks like many inflammatory conditions. Just to summarize, this is on any textbook. That's what you're looking for in early mycosis fungoides. Look for these atypical lymphocytes that go into the epidermis in a disproportionate way, disproportionate epidermotropism, so and so. I'm just going to show you a typical case of early mycosis fungoides, something that comes to you as rule out mycosis fungoides. Then if you see this very nice perivascular infiltrate, and that's one of the tips for the residents too. Whenever you have a lymphoid lesion in the skin that, most of the times anybody is like, oh, I don't know what to do with this. There's tons of lymphocytes. Okay, look for clues. And the clue in the Tcell lymphomas is look for those atypical cells. And the atypical cells are actually in mycosis fungoides the ones that go into the epidermis, so the epidermotropic ones. So if you have to pick one cell to make your diagnosis, go to this. So these are the ones who are going to be a hyperchromatic, are going to have the halo, all the features you can read in your textbooks, the cerebriform morphology, et cetera, et cetera. So, what is that? Oh, okay. Oh, okay. I thought it was a question. I think like a good.
It was a question.
That's a question from Siri. Okay. So if you're really lucky, you're going to find this, right? So microabscesses. These were called Potrie microabscesses. That's a misnomer because Potrie didn't even describe this. But anyway, now we can still call them Potrie microabscesses. So very atypical lymphocytes, right? A hyperchromatic, cerebriform. They look like little brains. They are surrounding central or a few central Langerhans cells. So if you have that, you're lucky, man, you can make your diagnosis. But life is not perfect, so there are many instances when you don't have this. The beauty of being a dermatopathologist and a pathologist in general is that you need clinical correlation. And an easy way for us to get rid of the case, if you want, is to, as we do it many times, in our report to say, okay, I think this is an atypical lymphoid infiltrate, and I think it has epidermotropism. And I just leave it like that. The dermatologist who is expert in the field is going to put this together. And I don't need really to say mycosis fungoides. If the dermatologist thinks that this clinically is mycosis fungoides, with my pathology report saying atypical lymphocytes with epidermotropism, that's it. He is going to treat, or she is going to treat the patient as mycosis fungoides. So you don't need to go really far. Unfortunately, histopathology is very subjective. Sometimes you have to see quite a few cases of mycosis fungoides to be comfortable calling something atypical or not. Sometimes lymphocytes may look very atypical, and they are not mycosis fungoides. And this is, again, the beauty of communication. So sometimes you have to really call your clinician and say, you know what, I don't see this very clearly, take a new biopsy. And they're going to thank you. Believe it or not, they're going to be appreciative of your honesty, saying, I cannot really reach a diagnosis, but, maybe one additional biopsy may help. Maybe if you stop the topical therapy the patient is putting, because this patient, try everything and nothing works, wait for 2 weeks, take a new biopsy, you will see it better. So again, communication, okay? Then, of course, we have in the fancy things, you can do immunohistochemistry, and that's the panel that we have at MD Anderson. So I'm sure you have panels here too, so I have a panel that reads lymphoma. So I just click a button and immediately I get all these markers, right? CD3, CD20, 4, 8, 30. If needed, as a second tier, second round, I may use these markers that I'm going to discuss later. So the case that I show you, the typical one, is going to be like that. Now you know that you have to focus on the epidermotropic lymphocytes, right? So forget about these guys. Most of the times are quite confusing. So CD3 highlights very nicely the lymphocytes in the epidermis. They are mostly CD4, negative for CD8. There is loss of CD7, boom, perfect immunohistochemical profile, great for MF. If you still want to do some molecular, tests, and then you can do TCR by either PCR or by next generation sequencing, whatever you want to do, to prove that this thing is clonal. Make sure that you are aware that even if it's clonal, it doesn't mean necessarily that it's lymphoma, and if it's not clonal, doesn't completely rule it out. Okay, so everything is in context. Everything is context with the patient presentation, the histology, the immunohistochemistry, and so forth. So you put all together, and then you can make the diagnosis. Now, so far it's easy, so you can go home and then say, okay, well, I can deal with this case. Well, unfortunately, there are many variations of the theme. This one, for example, and then now I start to show you the kind of weird cases that I guess you may find interesting. Came to us as MF. Of course, now I know my MF lesson, right? For the residents, I go back to my microscope, immediately look for the epidermotropic lymphocytes, right? They must be there. I don't see them very well on H&E. Okay, let's do immuno. CD3 highlights like maybe 3 or 4 cells. CD4, maybe 2. CD8, 1. What's going on here? This is MF. This is supposed to have epidermotropism. Where are the epidermotropic lymphocytes, right? And then, of course, as you learn from the first year in residency, you have to look at the whole tissue section. And then, if you go very deep, you will see some eccrine ducts here that they have the CD3 positive T cells that are CD4 positive cells, and they are negative for CD8. This case lacks epidermotropism, but has syringotropism, which is called also adnexotropism, can have follicular tropism. So there are variations of the theme. This case, for example, is a syringotropic MF. Doesn't have epidermotropic lymphocytes, but this is still mycosis fungoides. And the clinical presentation is completely different. This is actually a case of folliculotropic MF that presents not in non-sun exposed areas, but on the scalp, like in this case with areas of alopecia. So it's completely different clinical presentation. If you are not aware of this variant of mycosis fungoides, you may be completely lost. So again, call your clinician, talk to them. And then, of course, you have a long list of all the variants of mycosis fungoides, all the phenotypes you can imagine. It is folliculotropic, syringotropic, granulomatous. So it's like anything you can imagine MF can make, and all the clinical variants of MF, just for you to be aware. You most likely will encounter a typical case, but every now and then you will have something that doesn't follow the rules. And one of those, of course, is drug reactions. So if I have to say something in DermPad, melanomas can look like anything, syphilis can look like anything, drug reactions can look like anything. So this is a drug reaction that has tremendous epidermotropism. Look at the number of CD3 positive T cells. So this has to be mycosis fungoides, right? It's negative for CD4, it's positive for CD8. Boom. Well, it's actually the patient just started a therapy with a new drug and got this rash. So you may look for some clues histopathologically, but probably the most important one is clinical history, right? Again, clinical history. If you can ask the clinician, could you try to stop the new drug that the patient is having and see, like in a few weeks, how it goes? And sometimes the rash goes away. It's just because of the drug, right? Usually CD8 positive, sometimes CD4. Now the thing is that you expect this to be polyclonal, but sometimes they are clonal. Sometimes they are very atypical. So everything in context again, everything with clinical information. So this is the list of medications that can give you this. And just to wrap up MF, this is a review that I've just published like a month ago, Modern Pathology. And this is the most beautiful example of clinical pathological relation. This is Pimpinelli's algorithm. Pimpinelli is an Italian dermatologist who came up with this algorithm in 2005. Then the United States Cutaneous Lymphoma Consortium adopted it. And it's basically a scoring system. So you have 2 points for clinical, 2 points for histology, 1 for molecular, 1 for immuno. If you have the perfect case, you have two points for clinical, and you have epidermotropic atypical lymphocytes. You have the 4 points. That's it. You have the diagnosis done. If anything, some of the either clinical or histological features are not typical, you may want to do the immuno, gives you 1 more point if it's the perfect immuno, or molecular, if it's clonal, it gives you 1 more point. It's not perfect, but it works most of the times. I have this in my mind. Whenever I see a mycosis fungoides case, early case, apply it, and then you will be out of trouble. So of course, now we go into the more research part. So is there any magic bullet, any magic marker that is going to really tell apart mycosis fungoides early stage from dermatitis? Well, there are some attempts. Tox is one of these markers that has been published a few years ago. This is MF, positive for tox. This is an inflammatory condition, negative. And there is a follow-up on this also showing that there is supposedly a very nice, it's a very good discriminator. Actually, one of the beauties of this marker apparently is that this is large plaque parapsoriasis, one of the inflammatory conditions that mimic MF, and actually that one is basically negative. So I guess we may see this, we may use this in the future, but for now, again, I will stick with my clinical correlation. So if you want to try these markers, these new markers, we are building our experience on this, but still we are not there yet. There is apparently very good correlation. GATA3 is something that I'm going to talk a little bit later on. Seems that to regulate tox, and GATA3 is, besides all the other uses that you have in other areas of pathology, in HemPath and in DermPath, we use it as a Th2, T helper 2 marker. And most of the MF, mycosis fungoides cases are going to have T helper phenotype. So it's supposed to be positive in mycosis fungoides. Another marker is this CADM1, which again has been reported to be very specific for early stage MF. Here again, early stage MF, which is positive according to the publication, and pityriasis lichenoides chronica that is negative. But if you can see here, I don't see that very well. Unfortunately, the cutoff was 5%. So, and then they use double immune stain. So you can imagine that kind of, at least in my mind, that's kind of hard to really make sure that this is working or not. But it's one of the markers that is out there. And just going beyond the skin, because we are always trying to do something beyond, this is a fibrinogen-like protein 2 is a blood marker. So we don't need skin anymore maybe for the new pathologists. This is a blood marker that's supposedly to be positive in MF and negative in inflammatory dermatitis. So we will see how it goes, but so far, look at your patient chart, talk to your clinician. Now, I'm going to talk about the, I don't know how, okay, I still have a lot of time. So I'm going to entertain you with some non-mycosis fungoides cases, which I think because they are really nice examples of what clinical pathological correlation is. And this is the 2016 revision of the WHO classification. I'm highlighting there those entities that changed from the 2008. So some entities were upgraded, some entities were downgraded, and we're going to go over a few of them just to give you a flavor of a little taste of what mycosis or cutaneous lymphomas are. So the CD30 positive T-cell lymphoproliferative disorders is the second largest group following mycosis fungoides, then you have CD30s. And this is really a kind of very heterogeneous group. And what I want to show you is actually a real case. So this case is came to us because the patient was really worried. This biopsy was seen by a very famous, well-known dermatopathologist with expertise in hematopathology, so expert in cutaneous lymphomas. And as you can see there is a few worrisome features. There is a lot of course, lymphocytes. There is hemorrhage, and whenever you see hemorrhage in skin associated with lymphoid processes, you think of cytotoxic processes, which are in general not very good. And then if you go to higher power, you will see the lymphocytes here. They are atypical, and they are really epidermotropic. So you do your immunos, and this is actually CD8 that highlights most of the cells. So the diagnosis in this case was this entity, CD8 positive, aggressive, cytotoxic, epidermotropic Tcell lymphoma, which is a provisional category in the WHO. And since the name is so long, we just call it Berti lymphoma, because Berti is an Italian. These Italians are everywhere. Dermatologists who describe this tumor, and actually, it's a very bad tumor. So usually patients die. If you make this diagnosis, the patient has a horrible prognosis. So the patient, of course, went to MD Anderson because he wanted to be treated. And I was lucky because our dermatologist actually said, okay, let's take a new biopsy. Now I got a punch biopsy, so I can see better, right? So also depends on the type of specimen you get. So now I see that the infiltrate going deep. I see the ulcer. I see there's a lymphoid process. And since I'm a dermatopathologist, I have a lot of imagination too. So I can think like, well, I may be kind of wedge shaped, it's kind of like, okay, sometimes you want to fit things in categories. Okay, so let's do the immunostains. First of all, of course, these are the atypical lymphocytes, very atypical, very hyperchromatic. This is kind of scary. And these are the immunostains. So this is CD3, negative for CD4, definitely CD8 positive. But what was missing is this, and actually I'm talking about CD30s. And CD30 was diffusely positive. What's wrong here? Berti lymphoma is usually negative for CD30. So there's a red flag. There's something here that it doesn't fit again, right? But on the CD30 actually highlights all the cells and highlights the epidermotropic cells. So there's no question that this is a CD30 positive process, whatever that is, because CD30 is very non-specific. But still doesn't fit the Berti lymphoma business. So what I'm missing here? The clinical, right? What is the clinical? How the patient presents? I mean, this must be awful. The patient is almost dying, right? Okay, well, this is the patient, okay? So little papules that come and go. This is the lesion where the biopsy was taken. So this is not the presentation of Berti lymphoma. The patient is not going to die. What is this? This is lymphomatoid papulosis. It's a benign diagnosis. So the patient went from, death sentence to, oh, this is benign, we don't need to treat you. Okay? And it's just because of the clinical presentation, right? So the WHO until 2008 recognized these three entities, A, B, and C. And I love lymphomatoid papulosis. Why? Because it's the great mimicker too. There are so many mimickers. So type A looks like Hodgkin. If you see something that looks like Hodgkin skin, please don't make the diagnosis of Hodgkin skin. I've seen one case, and it's not like I see all the cases, but it's extremely rare. So if something looks like Hodgkin, think twice, 3 times, maybe LYP type A. LYP type B looks like mycosis fungoides. LYP type C looks like anaplastic large cell lymphoma. And the new one, that's the one that kind of fairly new, is the type D one that looks like Berti. So mimics Berti, but it's completely benign process. It's CD8 positive. And we did, at that time, was the largest series of LYP type D, but now there are more reports about it. And then we, elaborate this table in the publication saying, okay, there's all the things that can be CD8 positive and CD30 positive in skin. Berti can be CD30 positive, but it's usually negative. Okay? So nice example. This is the Berti lymphoma. So you can imagine that clinically, if you just see the patient, this is no way similar to the LYP, the little papules that come and go, right? And this progresses, the patients usually do very poorly unless you do something aggressive like chemo or transplant or things like that. That's the histology of Berti lymphoma. Okay? So now we come with the type E LYP, which is the one that is angioinvasive, and therefore it mimics extranodal NK T-cell lymphoma. So it's another mimicker. Then we have the type F, the one with translocation. You can have gamma delta phenotype in LYP. You can have intralymphatic involvement. Why I mention this, because these two are usually indicators of a bad entity. If something is gamma delta in lymphoid things in skin or in general, usually is not good. But the good news about that, at least for us pathologists, is that all these variants, they all behave very well. There is no need to do anything else. The only thing you need to do is to know them, because otherwise you can make the wrong diagnosis, right? The other end of the spectrum is anaplastic large cell lymphoma, the primary cutaneous one. And here's when I start to brag about dermatopathology, right? Because all the cutaneous lymphomas that we see in skin are similar, but are not the same as other lymphomas in lymph nodes and other organs. So we in skin are unique. We have these very special, specific types of entities. And this is one of those. In the past, you used to say, these are ALK negative, whereas the systemic ALCL is usually ALK positive. So if you have a tumor that looks like an anaplastic large cell lymphoma and is ALK positive, most likely it's not primary from skin. Well, that's not completely true. This is the clinical presentation of anaplastic large cell lymphoma. This is very typical hallmark cells like you see in the lymph node. This is one of our patients with a tumor on his forehead, and this is the histopathological features, very deep, and the cells are large and look like immunoblasts or hallmark cells, et cetera, et cetera. Be aware of the few cases of ALK positive primary cutaneous ALCL. So nothing is absolute in pathology, so there you may see a few very rare cases of ALK positive primary cutaneous, and they are still good. Why is important to distinguish primary cutaneous from systemic? Well, because the primary cutaneous ALCLs are much better in terms of prognosis than the systemic ones. So that's the thing, and this is one of the cases reported in the literature of a primary cutaneous ALCL positive for ALK1. So be aware of that. That's kind of like the new, relatively new thing in this field. Another problem for us dermatopathologists or hematopathologists is when a patient presents with something that looks like an anaplastic large cell lymphoma, but the patient has a history of mycosis fungoides. And then the question is this an anaplastic large cell lymphoma in a patient with mycosis fungoides, or is this large cell transformation of mycosis fungoides, which is bad? There is no way to distinguish them histologically. They look the same. In a patient with MF, mycosis fungoides, usually what is going to happen is that the patient is going to have large cell transformation. But if you want to do some markers, here you go, GATA3. GATA3 is positive in tumor MF, negative in ALCL according to the literature, and this is one of the cases. So I have this case, I don't have clinical information, I want to know if this is ALCL or is this is MF with large cell transformation. Okay, I can do a lot of T-cell markers. If there's loss of pan T-cell markers that favors ALCL, if I do GATA3 and it's positive, that favors MF. So those are the cells, large cells, atypical cells, CD3 positive cells. There is some loss of CD4 and CD8, kind of double negative phenotype. This is CD30, and because it's double negative, I'm going to go into this later on. I did beta F1 to see if this is alpha beta or gamma delta phenotype, and it's alpha beta, and this is GATA3. So GATA3 is strongly positive in this type of lesions that would favor MF. It's not 100%, but if you have this dilemma, you can use GATA3. Okay, now going to show you something, and I'm originally from Peru, from Latin America, South America, and this patient actually came to us when I was at NIH from Peru. Actually, I saw it with one of my professors there, and this is a skin biopsy. So you see this perivascular lymphoid infiltrate. It's not very atypical, so you say, okay, well, it's probably something inflammatory, I'm not sure. We took a second biopsy, and here, now it's worrisome, right? So whenever I encounter this in my practice, I said, if you see lymphocytes going deep, that is not good. So keep an eye on this. So this is kind of worrisome. And the cells become a little bit more atypical and more pleomorphic. And that's the description. And we did that at NIH. So these are all immunos, CD3 positive, CD8 positive. 4 is kind of weak or negative. And this is a cytotoxic marker, TIA1. So we are facing a CD8 positive T cell process, which is cytotoxic. And if it is also granzyme B, so it's activated cytotoxic. So it's kind of like, worrisome. And whenever you have that in a patient who comes from Latin America, because those are endemic areas for Epstein-Barr virus, you may think, oh, this is an extranodal NK T-cell lymphoma. This patient also has a poor prognosis. This patient probably is going to need aggressive therapy and is going to die. Okay? But what else? Well, of course, I'm going to need to do EBER, and then this is EBER. So almost every single cell is positive for Epstein-Barr. Okay? So definitely this is CPB positive. I'm worried about this patient, what's going on with this patient. Again, what I need to do? Look at the clinical. So this patient is an adult patient who has had this for years, for almost 20 years. Started with little papules that then became vesicles, then left scars. And for the dermatologist in the room, that is Hydra vacciniforme because it looks like smallpox, like the scars that smallpox leave. Also, sun-exposed areas, not sun-exposed areas. The patient was otherwise okay. So there is a disconnect between the biopsy that looks awful and the clinical that is not that awful. So what is this? This is Hydra vacciniforme like T-cell. And actually, the change now in the 2018 revision is now it's a lymphoproliferative disorder. No, it's not a lymphoma anymore. And why? Because some patients like this actually do pretty well, right? This is a very fascinating disease. Hydra vacciniforme is usually in Caucasians. In Scandinavian countries, you can see that it's seasonal type of dermatitis. And this is actually more in children from Latin America, from Asia, from Korea, from Japan, where Epstein-Barr virus is endemic. This is the clinical presentation. And a lot of these children actually died because of this, but apparently not because of the disease, because the children were treated aggressively with chemotherapy back in the 90s. And actually, apparently, they died because of therapy rather than because of the disease. Because at that time, we didn't know what it was. I mean, it looks awful, right? Looks like lymphoma. This has to be lymphoma. The patient is going to die. Let's do chemotherapy. And these poor children, some of them at least, died because of the therapy. Now we know, and then there's some better therapy for these diseases. There's some variations that I'm going to go over. Adults may behave a little bit more atypical in terms of clinical presentation than the children. But the truth is that this is a manifestation of what we call chronic active EBV infection. And when you have chronic active EBV infection, you have two things. You have hypersensitivity to mosquito bites, very severe. So you had a mosquito bite and then it's like a crazy dermatitis. Or you can have this Hydra vacciniforme like EBV positive lymphoproliferative disorders. So it's a spectrum. And actually, that is the beauty of this case. And again, a disconnect between histology without clinical, you may be completely lost. This is another entity that I've been studying the last few years, and I think it's another fascinating one. Whenever you think about primary cutaneous gamma-delta T-cell lymphoma, you think of this, horrible lymphoma, patient is going to die. Lymphomas that are deep, like subcutaneous and dermal, hemorrhagic, and then cytotoxic. This is one of the cytotoxic lymphomas. But every now and then you may have a biopsy like this. When I got this, I said, what is this? Is this mycosis fungoides, like going back to the beginning? Is this even a lymphoid issue? Because it's so bland, right? I mean, there's like a few, just 1, 2, 3, 4, 5 lymphocytes in the epidermis. Then you do your immunos, and then since you know that where to look for the immunos, so you're going to focus on the epidermotropic cells. So forget about these guys here. So this is CD3 positive cells. There are a bunch of CD4 positive, but the epidermotropic ones, if you have good eyes, you will see that they are negative. And same for the CD8. So double negative, oops, wait a minute. That's something that may raise a red flag. So if you have something that is double negative for CD4 and CD8, do your TCR beta, it's actually negative. You do your TCR gamma, that time we did it, now we do the TCR delta, and then you will see that the cells are positive. So gamma delta phenotype, wait a minute, this needs more attention. Because some of these cases may behave not as bad, but according to at least to our series, these are more aggressive than the regular MF. I'm going to show you that in a moment. So whenever you see an MF that looks double negative, do your cytotoxic markers, think about gamma delta, and interestingly, if CD7 is lost, usually in MF, here is preserved. What is lost is usually CD5, if that helps. So bad tumor, right? 5-year survival rate of 33%. But I was telling you, there are some cases may present like MF, like this case here that we published this series 2 years ago, actually of purely epidermotropic gamma delta T-cell lymphoma. And then this lady, I remember her very well because she started like a little, bump on her hand. Actually, a biopsy was taken. It was called pagito reticulosis, which is a, form of mycosis fungoides. Then the bump started to grow and grow and grow, and then it started to disseminate. This poor lady had a transplant, and then the disease recurred after transplant. Then she got a second transplant, and the disease recurred after the second transplant. So you can imagine how aggressive this thing is, that something that looks like nothing at the beginning. So this is the opposite, right? Like the histology looks like nothing, but the biological behavior is really bad. So if you compare the epidermotropic ones with the typical gamma deltas, those who go deep into the dermis and the subcutis, actually these behave better, but they behave worse than the MF. And it's just to show, this is the epidermotropic gamma delta with double negative CD4, CD8. This is gamma, and this is the typical gamma delta that you think about when you talk about gamma delta T-cell lymphoma, dermal subcutaneous with the same phenotype. So this is a variant of gamma delta. We wanted to go further and say, well, are these really different from MF? Okay, let's try the T helper markers. Because MF, as I mentioned, is a CD4 positive tumor that most of the times it can be CD8. That is a T helper phenotype most of the times, whereas gamma deltas shouldn't be, right? And actually, we demonstrate this in a paper last year, saying this is the primary cutaneous gamma delta T-cell lymphoma that is basically negative for all the T helper markers, whereas the MF is positive. So these are different beasts, at least for me. This is still controversial. Some people believe that these are mycosis fungoides with gamma delta phenotype. I personally think this is gamma delta T-cell lymphoma with epidermotropic part. Well, we will see in the next revision of the WHO if this is accepted or not. All right, so now moving to another interesting lesion. So this is a new entity. And until 2 years, we didn't have this in our classification. Now we have it. Primarycutaneous RL CD8 positive T-cell lymphoma. Initially described as indolent proliferation on the ear, and actually then described on the hand, so we changed the name to RL. And this is what you get, a nodule on the ear, and then when you see the biopsy, it's horrible most of the times. It's very atypical, so you are worried. Again, look for clinical, look for help. Show it to HIMPAD, do something, right? So these are medium-sized cells, sometimes marked atypia, positive for CD8. There may be some loss of T-cell markers. They may be even positive for cytotoxic markers, but they are not activated cytotoxic ones. CD8 positive. What is clue, again, is the clinical presentation. It's just one nodule there. Patient is otherwise fine, doesn't have anything else, very indolent. Some people describe a CD68 dot-like positivity like here, but the bottom line is, again, very indolent. I don't know if this is going to stay as lymphoma in the new revision, like in 5 years. Maybe we are going to talk about lymphoproliferative disorder again instead of lymphoma, but just for you to know, these things may happen. The last T-cell process I am going to show you is this one that is may be a headache sometimes. So comes with no clinical information. This CD4 small to medium size T-cell lymphoproliferative disorder in the WHO 2 years ago was called lymphoma. Now it has been downgraded to lymphoproliferative disorder again because it's very indolent. When we did some genomic studies on this by CGH in collaboration with Dr. Berti in Italy, actually we didn't find any. So it seems that this very inflammatory-like process. But when you see the biopsy, this is like, oh my God. This has to be a horrible lymphoma, right? I mean, this has to be something the patient is going to die. Let's do immunos, CD3, tons of T cells. But wait a minute, you have to do the CD20 oops, tons of B cells. All right, wait a minute, is this a T cell process? Is this a B cell process? Because low-grade B-cell lymphomas can have a lot of T cells. Or is this a reactive process, right? So if you do the CD4, CD8 business, you're going to find that there is a lot of CD4s, a good number of CD8s too, and this is probably what makes the diagnosis. These markers are T follicular helper markers, CXCL13, this granular positivity, and what is beautiful is this nice rosetting of the cells, positive for PD1. This is a T follicular helper phenotype process in the setting of just one lesion on the head and neck makes the diagnosis of CD4 small to medium-sized T-cell lymphoproliferative disorder, which is a completely indolent process. You can do a TCR for clonality, and it's clonal many times. This is actually one of the patients in our publication many years ago. That shows that's how it presents, just a little bump on the head and neck. Biopsy, scary. Clinical presentation, not. Be careful. Okay? So is there a malignant counterpart of this? It may. We are still not there yet, but I have seen personally like 2 or 3 cases of true lymphomas, aggressive lymphomas with T follicular helper phenotype that are not mycosis fungoides, and they may be a new category in a few years, but we will see. So, be careful with this. I guess this probably is interesting because not many people may agree with the name, but I would say whatever name you give to this, make sure that your clinician understands what you're talking about. So if you call it a typical whatever and I don't know what it is, call your clinician and say, you know what, I think this is. That's much better because I've seen cases called CD4 small to medium-sized lymphoma, and the patient has been staged, has been given chemotherapy because the oncologist freaks out because they read the word lymphoma and they think that this is a horrible thing and the patient needs really therapy, and it's not the case. In this case, just needs a little bit of surgery, a little bit of steroids, and patient is cured, right? Very good prognosis. So just to summarize this on the T-cell processes, this is a publication, recent publication of kind of like the clinical and pathologic characteristic of these tumors. And again, stick with your WHO classification. So I don't know, I think this may be dense, but I guess probably the idea is for you to keep an eye, always be aware that before making the diagnosis of a T-cell process in the skin, you know what is going on with the patient. I have the second part of the lecture on B-cell, but I don't know if do you want me to do it very quickly, or do you want me to stop here? I mean, I know some of you are sleeping. B-cells, okay, good. Let's go for the B-cells. Now, the B-cells, only 20% of the cases. These are a little bit rarer, but there are a couple of interesting things I'm going to go over quickly of kind of new things on B-cells. So again, 25% of the cases, and the one that you're going to see probably quite often is the marginal zone lymphoma. Just to prevent you, marginal zone lymphoma, primary cutaneous, is not the same as marginal zone lymphoma in the lymph node or in this GI tract or anywhere else. It's unique because we are unique in derm, right? So external marginal zone is that. And for the B-cell lymphomas, again, clinical presentation. And the rule for the residents, even for the boards or whatever, lesion on the head and neck, follicle center lymphoma. Lesion on the chest or the upper extremities, marginal zone lymphoma. And this is a nice cartoon by Tony Subtil. Follicular center lymphoma, marginal zone lymphoma, diffuse large B-cell lymphoma leg type. So just by knowing where the lesion is, you have a lot, you have like, again, 50% of your diagnosis. It's on the head and neck, follicular center lymphoma, marginal zone lymphoma, diffuse large B-cell lymphoma, okay? But it's not as easy as that, I wish, but at least, that helps. So this is on the arm, must be marginal zone lymphoma, just one lesion, maybe sometimes a couple of lesions. Weird presentations like anything, but most likely you're not gonna see that. And like any marginal zone lymphoma, the neoplastic lymphocytes are just a few tons of reactive cells, right? You have lymphocytes, you have eosinophils, etc. If you want to do IGH, be aware that almost 50% of the cases are going to be clonal not because they are not lymphoma, but because they have somatic mutations that prevent the primer of the PCR reaction to anneal with the DNA. So that's kind of like a false negative. And in contrast to other marginal zone lymphomas, then you have the GI, right? You have Helicobacter pylori that, causes this proliferation of lymphocytes. Then they got these translocations. Then you have the marginal zone lymphoma. Then you have more genetic abnormalities like loss of P16, whatever, and then you have diffuse large B-cell lymphoma. In skin, we don't have that. People thought of Borrelia in Europe, never in the US. And actually, the translocations that you see in other organs are very rare in skin. So again, we are different. And that is the thing. This is the real case. Dermatologists are sending us, smaller and smaller biopsies anytime. So we pathologists have to deal with little things. And this is a shape biopsy. Like in Tcell processes, I would say pick an area that you think is going to be the most informative one. If you go around like crazy, you're not going to get anything. So in this case, I picked this area. CD3 negative, CD20 positive, CD21, just a little bit of germinal center here. These cells are negative. BCL6, they're all over. I see this all the time. Don't pay attention to BCL6 in this pattern. BCL2 is positive on those, so it's a B-cell process that is BCL2 positive. But the most important thing, of course, is to demonstrate that there is light chain restriction. So this is kappa restricted over lambda. This is marginal zone lymphoma. Next case, very nice. Very good prognosis. You are happy. Now, if you want to impress your clinician or your colleagues a little bit, you may think, there are two different types of marginal zone lymphoma. One that is the good one, and the other one that is very rare, that is not the very good one. That is called class switch. And just for you to remember, class switch lymphomas express IgG. Non-class switch, which is the bad one, in between quotes, express IgM. I've never seen one of the bad ones, by the way, because there's very rare. So you have CXCR3 marker, which is a marker of this bad one, lambda restricted, and IgM. In contrast, what you have most of the times, and if that's the fancy thing, again, to impress your colleagues, do an IgG. So most of the plasma cells are going to be positive for IgG, which means that this is one of those that are going to behave very, very well. They don't go beyond the skin. Patient is basically cured with topical therapy. If you're going to want to impress even more your colleagues, you can do IgG4. And then you'll see that in many cases that those cells are going to be IgG4 positive. And then you're going to say, oops, is this an IgG4 sclerosing disease? Actually, no. Because IgG4 can be seen in primary cutaneous marginal zone lymphoma, in contrast to other lymphomas, like the nodal marginal zone lymphomas that are not positive for IgG4. Again, that makes us unique, right? And that's the thing. So the marginal zone lymphomas on the adnexal, on the ocular adnexal are also positive for IgG4, so be aware of that. We just had a frozen section of a little lesion of a doctor, happened to be a doctor who was not worried, and happened to be, IgG4 positive, marginal zone lymphoma. It's not a big deal, but it needs to be treated. What is the beauty? With your report, the clinician is not going to do anything else, because these patients don't need bone marrow biopsy or anything else. Just based on your report, that is going to be, the patient is going to be handled. And usually very well behaved, usually a little bit of radiation, a little bit of steroids, a little bit of rituximab if this kind of not responding, and that's it. The other low-grade B-cell lymphoma is the primary cutaneous follicle central lymphoma. I'm just going to say 2 words about this one. This one, as I mentioned, is basically on the head and neck, in contrast to the other one. And here is when your cytology is going to help you, because then you have to remember your years of residency and what the centroblasts and what the centrocytes look like, and look for them. This is one of the kind of difficult cases because it has this pattern that is diffuse and also follicular. When the follicular ones are very nice, and you look for the anaplastic follicles, and that's it basically. On this one, you may want to do some immunos, and these are the ones that I'm telling you: centroblasts, centrocytes, cleave, non-cleave cells, for those of you who train a little bit earlier. And basically, this is the immunostain. Again, pick an area, right? If you see the whole thing, you're not going to find anything. Pick an area. So this is the area I'm going to pick. CD20 positive, CD3 negative, BCL2 negative, because again, the primary cutaneous follicle central lymphomas, in contrast to the nodal follicular lymphomas, are actually negative for Bcl2. So Bcl2 doesn't help here. They are positive for Bcl6. And another thing that I want you to remember, this is MUM1. If you want to call something MUM1 positive, at least in this setting, don't call it like this. You have to have a lot of cells, more than 80%, diffuse strong positivity, okay? So that's the phenotype that I mentioned. And just if you want to apply your HIMPAD knowledge in skin and then do Ki67, because Ki67 is high in reactive germinal centers and low in follicular lymphoma, well, guess what? It's not going to work all the time, because sometimes, like in this case, you're going to have high Ki67 in a follicular lymphoma. This is what you are supposed to get. This is what I got, okay? And then you go back again to your first year of residency, and what they teach you. Okay, the germinal centers have this polarization. Right? So Ki67 should show this nice polarization in the reactive germinal centers. You don't see that here, therefore this is abnormal. Okay, so use judiciously your Ki67. And then just to, again, this is indolent. In contrast to marginal zone, these patients need bone marrow biopsy because 10% of them may go to the bone marrow. So it's a little bit more aggressive than the marginal zone lymphoma, but it's still very good. And the one you really want to distinguish from this is the next entity, which is the primary cutaneous diffuse large B-cell lymphoma. That's the last entity. For this one, there is not really a big problem, because any one of you, if you look at a biopsy of this, knowing the clinical history that is really horrible on the legs, usually in older females, there's no really doubt that this is a bad lymphoma. The cells are really atypical. There are B-cell processes, and this is the MUM1 I was telling you. Diffuse and strong. This is what you want to call MUM1 positive, not the other one. Now, the beauty of this tumor is that now we know a lot more about the genetics. This is the clinical, this is the histology that I mentioned. And in terms of genetics, remember this mutation, MYD88, that, as you know, can happen in other entities too, like Wallstrom macroglobulinemia, for example. In the skin, in the primary cutaneous diffuse large B-cell lymphoma, you have the MYD88 and actually the beauty of this is that the non-L265P mutations are rare. And that makes this different from the nodal diffuse large B-cell lymphoma. And actually put it from the genetic point of view closer to the primary CNS lymphomas than to the nodal diffuse large B-cell lymphomas. So again, there is something unique about the lymphomas in the skin. To complicate more things, this is a Tcell lymphoma Sézary syndrome that shares some pathogenic pathways with the B-cell lymphoma. So at the end, they may be all the same thing. Okay, so this is the tumor. In contrast to the other two lymphomas, this is bad. This has a worse prognosis. If you encounter a case that looks like you are in between primary cutaneous follicle central lymphoma, diffuse pattern, or diffuse large B-cell lymphoma, think of Bcl2, think of MUM1. Bcl2 positive in the diffuse large B-cell lymphoma, MUM1 positive in diffuse large B-cell lymphoma, the follicle central lymphoma is usually negative. So if you have that, which is very important because this is indolent, this is bad, if you encounter a situation like this, try to do your best in order to make the right diagnosis. If anything helps, you can do the MYD88 mutation in theory. I never did it. So bad prognosis, worse survival. There are some markers for worse survival that's basically for clinical, and this needs chemotherapy, this needs systemic therapy, this needs targeted therapy. So this is a big, different beast, right? You need to call the oncologist. This is something that dermatologists usually don't handle. And, well, that's, I can talk 1 minute about this. This is the new entity in the B-cell lymphomas, described by Dr. Jaffe, so-called EBV positive mucocutaneous ulcer. Again, and this is actually a nice case to wrap up, clinical presentation is this, kind of impressive ulcer, usually older people, is associated with immunosuppression, maybe age-related immunosuppression. But even if this is impressive, and you can see the bone there, this heals by itself. And when you take the biopsy, this also happens in the oral cavity, it's very impressive. Why? Because the cells are awful. Again, they look like Hodgkin lymphoma. They look like diffuse large B-cell lymphoma. If you do EBV, of course, it's going to be positive. This is CD30, this is CD15. So again, looks like Hodgkin. Hey, stop. don't make the diagnosis of Hodgkin lymphoma, right? Now you know that it's pretty rare. Look at the patient, call your clinician. Is this just an ulcer on the mouth? That is just that, and the patient is otherwise okay? Well, could be EBV positive mucocutaneous ulcer, right? To complicate things, if you do clonality, it's clonal for B, can be also clonal for T, because there is a bunch of T cells in the base, and the immune response is restricted, so their repertoire is limited. So that's why it can be clonal for T. Just to leave you with this image, it looks awful. Sometimes looks like diffuse large B-cell lymphoma. And even for Dr. Jaffe, who is the expert, sometimes what she recommends is provide a differential diagnosis if you don't know the clinical. So before making a diagnosis of diffuse large B-cell lymphoma and trigger all the chemotherapy and all the aggressive therapy, call your clinicians and say, is this just an ulcer, just a solitary ulcer? Sometimes you have to just leave it with that. With that, I end. I hope I can awake you in a way that you really need to know the clinical presentation, plus the histology, plus the molecular in cutaneous lymphomas. These are unique tumors. That's why I like them. And of course, keep always communication with your clinicians. That's the best thing you can do, at least for now, until we find a magical marker that can tell you the answer. So with that, I want to, of course, thank you, my friend Alessio, who kindly invited me, and I'm really thrilled to be here. These are my colleagues in HIMPAD, which I consult a lot, and sometimes they consult me too. These are my friends in dermatopathology section, and that is my institution, and I'd be happy to take any questions. It's 9 o'clock. Yes.
Nice presentation.
Thank you.
Some of the Tcell lymphomas that you discussed were quite aggressive and patients tend to die. So what is the usual cause of that? Is it always systemic dissemination?
On the aggressive ones, yes, they may go to the lymph nodes, like even mycosis fungoides, goes to the lymph nodes, may go to the visceral organs, they may go to the CNS. Yeah, it's usually extracutaneous dissemination. That's what worries.
It's not unusual to encounter some of these for the first time from a non-skin biopsy.
Sometimes you may have lymph node biopsy, and then going into the medical record, you can say, oh, well, by the way, the patient complains about this chronic eczema for years and years, right? And then you come up with, okay, this was actually mycosis fungoides. Every now and then you may have the initial biopsy may not be skin, yes.
So when we see that, we either call Alexio or we call
Call 911. No, I think it's a good idea to show to HIMPAD, show to DermPad, because we have the advantage of knowing the clinical presentation and know the entities. HIMPAD are amazing, help, but sometimes they have so many entities that maybe skin lymphomas is not on top of their priorities. So, thank you.
I might just add, it might be useful to look in the chart and see if the patient has a history of any rash, because sometimes this is misdiagnosed or
That's true.
it's been a smoldering or indolent presentation. So that would a wise call would be to Alessio, but also just looking in the chart and seeing if there's any history of a diffuse rash or anything like that. I think could be helpful for finding a T-cell lymphoma.
That's true. Sorry, I was.
Cutaneous marginal zone lymphoma versus sputal lymphoma, you depend on the Cabala-ish?
Most of the times, yes. Sometimes you don't have a light chain restriction, but still, if you're lucky, you're going to have an IgH clonal. So in those cases that look like pseudolymphoma, and there are some cutaneous lymphoid hyperplasias that may be clonal, yes, you can push a little bit towards marginal zone lymphoma. Now, the good news about this is that both cutaneous lymphoid hyperplasia and marginal zone lymphomas are very indolent. So it's not really a big deal if you miss one, to be honest with you. It's going to be an indolent process, going to be treated topically, and it's going to be fine. So that's the practical part of it. Yes?
Any comments on the role of flow cytometry in cutaneous lymphomas? Sometimes with IHC actually incorrect easily, and there's a lot of...
Yeah, there have been efforts, and my friend Pedro Orna now at Mayo Clinic, he did a lot of Peruvian too, studies on flow cytometry and skin biopsies. And I mean, flow cytometry in general is cleaner than immunostains. I mean, then here you have to deal with many different types of cells, what is positive, what is negative. Supposedly good. In our institution, we don't do it for logistic, I guess, reasons. But yeah, there is a role for flow cytometry. Yeah. Yes.
You talked about a couple of cases that were CD8 positive with epidermotropism that had granzyme and perforin.
Yes.
Could you discuss the differences between those that are CD8 positive, negative for granzyme and perforin versus those that are CD8 positive, positive for granzyme and perforin?
Yeah, that's a good question because the usually when we do TIA1, we say this is cytotoxic, but granzyme B and perforin are more like activated cytotoxic markers. So in general, yes, those that are positive, at least in theory, they should be truly cytotoxic and more aggressive than the ones that are not. One beautiful example is the CD8 positive lymphoma of the ear, that being positive for TIA1 is negative for granzyme B, negative for perforin, therefore is not really considered that aggressive and is actually clinically not aggressive. So I would say if you have a cytotoxic or suspect on a cytotoxic lymphoma that is usually a aggressive lymphoma, I would do the whole panel, try to characterize better what type of cytotoxicity this lymphoma has, and go from there, but never forgetting, again, the clinical presentation of the case.
It generally indicates a more aggressive phenotype.
In general, cytotoxic lymphomas are more aggressive. However, cytotoxicity can be seen in things like LYP, lymphomatoid papulosis. Mycosis fungoides can be cytotoxic every now and then, and not necessarily more aggressive. Okay.
Any more questions?
Well, thank you very much.